Okay, so here we go. This is Chapter 3, Radiology, Advanced Coding, Next Step. Radiology. As with all of the other chapters, this is going to go into a little bit of detail or defining the different positions that a patient may be in to get an x-ray done. It's probably a good idea to be somewhat familiar with some of these terms. I think some of these terms are going to be in the front of your CPT and your ICD-10, so I wouldn't spend time memorizing them or anything like that, but it's a good refresher on how patients have to be positioned for some of the x-rays that they get. Component coding, this will go over your professional component 26 and your technical and your global, so this is good information to have. Interventional radiology, this is when your provider or physician not only performs the procedure, but also is going to interpret the radiological findings. So that's usually your interventional radiology. And those from a risk adjustment, if you're going to get into risk adjustment, interventional radiologists are approved providers, whereas just a regular radiology note or something would not be. Contrast, this kind of sums up the different contrasts that you have, what qualifies as contrast, what doesn't, what you can code extra for, what you cannot. Clearly, if you drink the contrast or if it's inserted rectally, that's bundled in, that's not anything that you would code extra for. Facility specifics, this is some information about your outpatient services at the hospitals and standalone facilities. Then you've got your diagnostic radiology. Remember, we've got to think back kind of about CPT, radiology, or diagnostic radiology. All of these cases will have to do with something in radiology. So I'm probably not going to focus too much on the odd cases because in a lot of ways the radiology codes aren't too hard to find. Sometimes finding the diagnosis codes in here are going to be a little tough, so I'm probably going to kind of help walk through some of that. But other than that, probably won't do a whole lot of looking up unless I get feedback that I need to do another video for looking stuff up. So, first of all, let's look at this case 3-1. So, the reason that a person is showing up is usually what your diagnosis code is going to be. So, again, really pay attention to your italicized. So this is a patient that has a hemodialysis catheter placed. They want to ensure, so they've had it placed and they want to ensure correct placement of that catheter. So the purpose for showing up to this moment in time is going to be encounter for a dialysis catheter fitting, adjustment, extracorporeal. So that's going to be this Z code, Z4901. Okay, so then you look over here, the impression support lines are mentioned. So all of this is probably saying that it's been placed right, everything's good. And then, actually, is this going to be follow-up placement of yeah, so follow-up placement for hemodialysis catheters. So they must have the patient, because they're still, what threw me is they're still intubated. They're still have an endotracheal tube. So this patient most likely is still under from surgery, and so they're checking placement while the patient's still under, so that if they needed to correct something, they could. So that kind of makes sense. The impression, this cardiomegaly with failure pattern, you could go on and code this kind of as a secondary because it is here in the impression. Isn't really pertinent to why they're having the x-ray. They're having the x-ray to check for placement, which is why the insurance company would pay for this x-ray. But you could go on. It's kind of an incidental finding. You could go on and code that as well. Same thing here. This is another line placement. So check your italicized. They're checking for placement of the line. And then your impression. So the reason to show up is to check for placement. So here's that status post placement. So that would be your Z code. And then incidentally, they're telling you that the patient's going to have some congestive heart failure as well. Here's congestive heart failure. So I would still code the placement, the Z code first, but I would include that congestive heart failure. Here is an abdominal x-ray. Clinical symptoms, they've placed a tube in to the abdomen. So they want an interim repositioning of the nasogastric feeding tube. So this is an abdominal x-ray examination of the abdomen. So that would be a 74000 code. You do need for this one, because it's an interim repositioning, think about, that's kind of a weird scenario. So let's think about our modifiers a minute. Modifier 76. So interim repositioning means it's already been put in. So 76 would be a repeat procedure. And I think you would need a 76 for this because it's that repositioning, which would not necessarily be normal. So I would use a 76 modifier, and then remember on all of these, your 26 professional component modifier. Okay, moving on. Chest x-ray, you generally need to know if it's 1 view, 2 view, 3 view, 4 view. This is a 2 view, which tells you frontal or lateral. So that's how you would pick that code. Looks to me like they have primary malignant neoplasm of the hilus of the lung. So to find that diagnosis code, I think I will go on. So I would go to this isn't the one that I have marked. I would go to the neoplasm and then lung. So I'm in the neoplasm, here's lung, and here's hilus. And they said it was primary, so right there, C34.0 with a check mark, so you've got to go verify that, C34. C34.0, did we have any specifics on here? So all we know, primary neoplasm hilus of the lung. Abnormal on the right side, frontal view. So let's see, C34.0. So then we have to find so this was, let me read, is it upper or lower lung? Blunting of the left posterior, pleural effusion, abnormal opacity. Best seen frontal, the patient has history of lung cancer, previously noted. So the impression, persistent opacity, right, suprahilar, so it's upper. Supra means above. Okay, so I would code the C3401 malignant neoplasm of main broncho. There's your hilus right there. And then I would put it over on that right side because that's where we have it's hilar and suprahilar. So I would put it on the right side. So I would code C3401. Okay, here's another x-ray of the femur. Again, make sure you're making note of the views. This is left. There's a mirror image, so you're going to use your 26 modifier and your LT. One thing, let's go back just a minute. We had two different modifiers here, a 76 modifier and a 26 modifier. There could be a question on how do you know how to stack your modifiers. I would typically, if a modifier is doing something to money, if it has money attached, so a repeat procedure could very well affect the insurance reimbursement, I would do it first. Your 26 modifier is going to affect the reimbursement. Well, the 26 modifier is money, but it doesn't, the provider is going to get their professional component amount, whatever that amount is. Your 76 could actually affect if the insurance company is going to reimburse that 100%, 50% because it's redoing or repeat. So that could affect money. Now over here, we have a 26 modifier for this femur x-ray, but we have an LT. So I would put the 26 modifier because that's notating how the chunk of money needs to be divided up, that this is just for the physician. And then I would put the LT last because that's providing specificity, but it really is not affecting the money. Hope that makes sense. Here's radiology of the knee. Again, make sure you know the views. So this is two views, left knee. So again, because there's a mirror image, and I probably have left off a 26 modifier here when I coded that. Okay, shoulder. This one is a little different because we have potentially two things. So these were films from 15 days previously, just now submitted for interpretation. And then we have two sets of films from 15 days ago, one at 11:20 and another performed at 1. Well, they're separate. They were separate, identifiable for those times. So you're going to have to do the first. This 11:20 is going to be the code with your 26 modifier with the RT for the shoulder. And then the 1 o'clock is going to be the same radiology code with the 76 because it was a repeat with the 26 with the RT. So that's how you would play those out. Do them one at a time and then just think through your scenario. KUB stands for kidneys, ureter, and bladder. It tells you right here. This is abdominal view. Again, this is to check for a tube feeding placement. You should be able to get that. This is a video swallow. That's actually, it sounds really involved, but that's a pretty easy code to get to for dysphagia. Your CAT scans, I grew up calling them CAT scans because I'm old. They're CT scans now. They're still CAT to me, but I think CT is the more readily accepted. Just like EKG, I still say EKG, and I think it's more acceptable to say ECG. So it's just the way it is. This is a CAT scan of the brain. Now remember the flow of your radiology. Under each body part, you have your x-rays, and then you have your CAT scans and your MRIs. It kind of flows. So you should have already marked your radiology books to where your eyes can kind of catch it a little bit easier. Sinuses. This is good information about some of these diagnosis codes, just kind of learning the disease process. Again, CAT scan of sinuses, CAT scan of chest, CAT scan of abdomen, another CAT scan of the chest. I think you'll be okay with these. They do give you, in the italicized, they give you good guidance that kind of helps you through. This case 316 is a little involved. It has a lot of diagnosis codes. So that's why Carol Buck has done this excellent discussion as to why you code those diagnosis codes and how you get to all of those different diagnosis codes for this CAT scan. CAT scan of the abdomen, CAT scan of the abdomen and pelvis, CAT scan guided kidney biopsy. Now these biopsies are a little bit different. It does have a good discussion here talking about the biopsy. So you're going to have radiology codes here, but you're also going to have your 50,000 or your urinary codes 50200. And this again has a repeat one. So you will see the 50200 bilateral, and then you'll see the 76 modifier for the repeat. Ultrasound. This gives good information about your M mode, B scan, A mode. What do you see? What is a Doppler? The different components the different wordy lingo things that you may see within the op note. This does a good job of kind of breaking that down. So now we're into the ultrasounds. Again, when you have a impression that tells you it's normal, then you have to go back to what the symptoms were, what landed them here. So let's see what the symptoms were. So they have right lower quadrant pain, chills, and fever. So chills, can't really do anything with that. So I would code the right lower quadrant pain and fever, since they did not come up with a definitive diagnosis. I think they were maybe thinking it was going to be appendix, but then it wasn't. Gallbladder, again, here we're having an ultrasound of the gallbladder, but it's normal. Nothing's identified. So again, there's no definitive diagnosis, so we're going to have to default back to abdominal pain. And this, we don't even have great abdominal pain. It doesn't tell us right lower quadrant, left upper quadrant. It tells us nothing. It's just real generic. Insurance companies hate those unspecified codes. They just hate them. This is an incidental finding. The right pleural effusion is present. That's lung. It doesn't really have anything to do with the gallbladder. You could pick that up. In the real world, it would depend on who you worked for and what their guidelines were, if you were going to pick that up or not. Wouldn't be wrong, isn't necessarily required either, because all you're trying to do is get this procedure paid for from the insurance. So all you have to do is establish your medical necessity. So for a gallbladder ultrasound, abdominal pain would establish the medical necessity. Clearly, the pleural effusion is not causing the abdominal pain. Ultrasound of the kidneys. Again, here it looks to me like we've got normal kidneys. They've come in with nephrotic syndrome, so that's probably what you're going to be stuck with. Enlarged prostate, you can do that, BPH. I don't think that's lower underneath the bladder. So that's really doesn't play a role in the kidneys. But you could add that. I'm going to remind you again to use your 26 modifiers. Your ultrasound of the gallbladder here. Again, if you do not have definitive diagnosis, you're going to have to default to what the symptoms were. This particular patient is on a ventilator. So make sure you code the Z9911 for that dependence on a ventilator. Renal ultrasound here. We got a lot of stuff. So we have chronic cholecystitis, so that's chronic gallstones, chronic renal failure. What else may be going on? Let's see over here. There's cortical, given history, multiple cysts are seen bilaterally. You're probably going to be able to find cysts on that kidney. And there's a large amount of ascites noted. So ascites is the collection of fluid, like, where was that dialysis? Sorry, didn't go back, but that's a really good picture. That was probably in medicine. Hold on. Let me find it real fast because I can show you ascites pretty easily. Okay, so here you go. So this is actually a picture of the peritoneal dialysis, but picture if this was your abdomen, all that yellow fluid, instead of being the solution you're putting in for dialysis, people with ascites actually collect that much fluid in their bellies and they get really, really big. And the treatment for that, they usually have a liver issue most of the time, or pancreas issue. They have to do a paracentesis, which taps into the abdomen and draws that fluid off with big syringes. So the presence of the ascites generally is an indication that there's something chronic and probably ultimately life-threatening that's going to be happening here. So those are the different diagnosis codes. For a renal sonogram, since it's kidney, I would probably use a kidney diagnosis first and then stack everything on. And it wouldn't necessarily matter, but I think I would do this chronic kidney failure first since they're doing a kidney sonogram. I just think that would stack the diagnosis codes better. Here, I think this is pretty straightforward, and I think you're going to be stuck having to go with the symptoms. The R code's there too. Retroperitoneal, I think that's the same. So clinical symptoms here was acute pyelonephritis, and that's probably what they found. Radiation oncology. This is the area that I spent a little bit of time on in the video, talking about we had to do a lot of labeling. What was the physician part, what was the treatment part, what was the management part. So that's what this consultation note would be. But this is not, this is as a consultation note, you're going to have an E&M for that because it's the consultation, it isn't the actual management. So these cases here, and you're very lucky that this whole case, so it's 29 and it has 4 or 5 scenarios with it. But it's all, your answers will be there in the book. But this is really a good description of how to break down the treatment planning part of it, the simulation planning of it, and you should have all of this already labeled in your ICD-10 or in your CPT, sorry. Here's 1 week of the treatments or the fractions. And then here's another progress note. This is week 2. So that's, I think you'll do okay with the answers in the back of the book. But that is a good enough example of that if you understand the codes that you put on, I think you'll be fine on the board. They don't have a lot of that on the board, if any. Some of the tests don't even have it. Pulmonary function tests, these are just kind of stinky, in my opinion. You're probably impression, triple match, lung base, so nothing. There's all this possible and indeterminate. We can't code possibles and indeterminates, so there's nothing definitive here. So you're probably going to have to go, I would code the hypoxemia, which probably causes the shortness of breath. I would not code the shortness of breath because I think that's a symptom of the hypoxemia. Finally, here's interventional radiology again, your central venous access codes. So this does a good job of kind of breaking down those 3600 codes. And then you may or may not need to pick up a radiology code with them. If they use some kind of guidance, then you would have to. So let's see here. So this is for placement of a hemodialysis catheter for chronic kidney disease. So what I'm looking for here is to see if so using sterile technique under ultrasound guidance, so that tells me we have to have a radiology code, unless it's built in the code, which it probably is not. So you're gonna have that 36,000 series code along with your radiology code for the ultrasonic guidance. Duodenostomy, gastroduodenostomy catheter placement, most likely the guidance or any radiological component's going to be built in this placement. And these are kind of all the same. So and here we go, we're back into the auditing. And then our next chapter will be the pathology in lab. So remember, if you have questions, your odd answers are in the back. A lot of times by advanced portion, you can sit and compare codes. Even if you've gotten it wrong, you can sit and compare and you do okay. If you have questions, let me know. If you need the even answers, let me know and I can get them for you. Okay, see you in the next video.